been able to digitize their training curriculum, beginning with the Masinde Muliro University, so that the universities can be able to offer these courses in a digital manner, so that we also improve access to other people who may not be available for the class-based learning. In addition, we've offered continuous capacity building or continuous tests, which will also add to their continuous professional development points using the AMREF Jibu platform. All these interventions have led to an increased recognition of these cadres, because right now they're now having, they are working in a space where they have clear-cut schemes of service, which will be able to guide where they implement, the space in which they implement, and in a sense, it makes them have a sense of belonging and a sense of recognition and a sense of worth in their working environment. So in the course of implementation, we've learned a few issues which I would like to share. Now, first is in the context of now addressing these cadres, because we realize that the more people you get together, the more the conversation is going, then the more you begin getting solutions to these issues. And it all begins by setting up a structured way of ensuring that the voice of everyone across different segments is heard, and they're working together to address the gaps which are there and which are affecting these cadres. So capacity needs assessment, we've also noted that it's quite critical, because it provides a basis for continuous capacity development for these cadres, especially the associations which are tasked with articulating the needs and the interests of the cadres. So that is really key. And the other focus is also on the neglected or unregulated cadres, because some of these cadres play a really critical role in the healthcare ecosystem. For instance, we have the health records information officers, and in this discussion, I know we are talking about neglected diseases. So if you don't get the correct data, you will not get the correct decisions. And it all starts with ensuring that these health records officers know what they're doing, that their background training is able to facilitate their forward decision and their work. So that focus is very important on the neglected cadres, because they're also part of the key players in the entire health ecosystem. And lastly is in the use of a dialogic change model. This is basically a result-oriented model where you put everybody in the same space, and first of all, you start with the needs assessment, then everybody really discusses what they need to do or to implement, and share their thoughts on how best to implement it, so that it's more a collective initiative rather than individual organization relationship. So this brings out the aspect of collaboration really well, and ensures that these cadres are recognized and in the long term regulated. So those are what I wanted to share for now. Thank you very much.
Let's give MSP another hand. What an impact MSP has had on those cadres, those healthcare cadres that have, didn't have systems to regulate them, didn't have associations, and the impact that the program has had on emergency medical technicians and the health records officers and the community health personnel is immense. So thank you very much, MSP, for the good work that you've been doing. We have noticed that there's been a change in this profession. At this point, we will shift focus, and we'll start talking about neglected tropical diseases. Can anyone on the floor shout one neglected tropical disease? so that we refresh our brains whether we know what NTDs are. Leishmaniasis. I think that's somebody from PSK. Well done. PSK is on top of things. Leishmaniasis. All right, another one. Soil transmitted helminths. My goodness, that one is so complicated. Mignon. Okay, mignon. Are all mignon soil transmitted? Okay. Soil transmitted helminths. So that's another one. In other words, mignon. I hear there are many. I think there's about 30. So maybe let's try 3 more guesses. Jiggers. I hear jiggers. Dr. Karutu, have we passed the exam, jiggers? Okay. But what's the disease of the jiggers? What is it called? We just call it jiggers? They will tell us. They are coming. A very high-powered team is coming to speak to us. A 4th one. Another neglected tropical disease. Trypanosomiasis. Hey, we are not behind at all. Our knowledge is fresh. Another one? Sorry? Elephantiasis. Okay. I don't know if that's the name of the disease. I think that's the name of the disease, but I was thinking of filariasis. Again, I can't explain the difference. I think these people will need to come and tell us. So we are moving into that session where we're going to talk about neglected tropical diseases and what role we as private healthcare sector can play to eliminate these diseases that are, some of them are in the last mile of being eliminated, and we can play a role. So we're looking forward to that session, but I'll just ask the team from KHF to play for us a video to set the stage. And this is a video telling how lives and livelihoods are placed at risk in the absence of treatment programs for NTDs.
Lake Victoria, what I can say about it, it produces a lot of fish and it used to help us. I sell fish. I take them from the fishermen. I buy at a certain price. I go and sell at the market for some little profit to sustain my life. In the lake, the water is not fit for human consumption. Cysto is rampant in the community because people do not use clean water. People around here stay for long hours in water. That is where they contact the disease because the disease are waterborne disease.
We wash vehicles to get our daily living. This one here, he is my customer and he trusts me. Sometimes I may spend 8 or 9 hours in the water. Before I started working here, I used to feel okay, you feel strong. And there are some that now I cannot do. I just feel tired. It's like you are growing old. The first time I heard about cysto, I feared. When you get into the water, cysto, the germs, they will feel the heat that is in the blood. They feel it, they run, and they get through your pores into your body. The blood moves, they will get into your stomach. After infection, your health will deteriorate.
As a community health worker, I've been going around the houses. I find many cases of cysto. You can see a child, the lips are dry, tummy swollen, even the feet are swollen, and the child or the lady or the man has lost appetite. You see, this leads to poverty, because when you are sick, you are unable to do your normal activities.
The first day I took the drugs, I can remember very well. It's like these things were actually so many in my stomach. After taking the medicine, I was now well. I could now be strong enough again to continue with my work as usual. Without that medicine that they give us, our life could not be sustained up to this moment. Many of us, even for me, I would maybe have died. So even though we have challenges, but you must just continue working hard so that you continue with life, your daily earning and other challenges. Yeah.
After they take the pill, there is a great change in the community. People are energetic, they do their activities, they are happy, they are healthy, and things keep on moving smoothly. We are happy because when you have a healthy community, people can share, can help one another. Yeah. Smoothly. We are happy because when you have a healthy community, people can share, can help one another. Yeah.
Ene murto. Ore dala teneton naji endama nabo naa naidip taisere. Ore naapa ninye nanu eton itu. Ene murto. Ore dala teneton naji endama nabo naa naidip taisere. Ore naapa ninye nanu eton itu abaki nkonyek naa kanyamal apa oleng. Maton ninye tenkolong. Ore enare esiai naijo ena naa maidim ataasa esiai naijo ena. Imintoki esiai kewan, imintoki esiai likae tung'ani, neeku naa enyamali tupu. Ore napa ponu nayieng nkonyek nalo natum dupoto oleng amu aewuo ake kadolisho naa kaidim aisiaiyia kewan. Neeku naa nara karipisho ore saa tano enkewarie natii ake ele kasi amu anoto naa faida oleng oonkonyek. Neeku naa todua nanu oleng esidano mekure nanu enyamal nkonyek katukul. Ishiutuo ninche nkonyek ainei pii. Neeku naa kadol nanu ajo ketii apa dupoto oleng tenanu amu etadolishe naa kabisa. Neeku naa kagira nanu ajo tenakata oltung'ani enyamal nkonyek naa etonyorrai mikitabaiki amu ketii faida.
I think we are now in a better position to describe a few more NTDs. Now, as we're waiting for our chief guest and people from Serikali Kuu to arrive, and they're just about, we will take a mic round. So, KHF team, please help me with the other mic. We'll take a mic round and let's know who's in the room. Please just let us know your name and the organization that you represent, just so that we know who's in the room. Maybe we can start from behind there. If you can take a mic there.
My name is Ronald Njoroge. I'm from Shinwa News Agency.
I think it wasn't very clear.
My name is Ronald Njoroge from Shinwa News Agency.
Okay, karibu sana, Mr. Njoroge. Next table. Just say your name and the organization that you're coming from.
My name's Catherine Gachango from Africa Medilink Limited.
Karibu sana.
My name is Emily Wahome, Queen's Nutrition Consultancy Limited.
Thank you. Welcome. I hear some names of new members. Thank you very much.
Good afternoon. I'm Charlene Malo from the Star newspaper.
Good afternoon. Margaret Wanjiru, Radio Africa.
Good afternoon. James Nyagoti for Pent Media.
Afternoon, everyone. My name is Arcadius Kubai, a freelance journalist.
Okay, we have a media table right there. Karibuni sana.
Good afternoon, everybody. Wesonga Margaret, Office of the First Lady, Kakamega County.
I'm Miriam Chelagat, Office of the First Lady, Kakamega County.
Good afternoon, all. My name is Kamau Maina, Kenya Medical Training College.
Karibuni sana from Office of the First Lady, Kakamega and KMTC. Next table.
Good afternoon. My name is Alan Luala from Health Passport Worldwide.
Hello, everybody. I'm Ethne Kibet from Dawa Life Sciences.
Karibuni sana, asante.
Good afternoon. I'm Gordon Odundo, Transact Cloud Services.
Thank you.
Good afternoon, everyone. This is Emmanuel from First Lady Bungoma County.
Afternoon, everybody. I'm Vincent Mnyasha, Office of the First Lady Bungoma County.
Felicitas Nekoe Butali, Office of the First Lady Bungoma County.
Karibuni sana watu wa Bungoma. Karibuni Nairobi.
Good afternoon. My name is Irene Chami from the End Fund.
Thank you very much. Later on, you'll tell us what the End Fund is about. Maybe we can, that's a speaker's table. Maybe we can start from the other table.
Good afternoon, everybody. My name is Eunice Wanjiko, Kenya Council of Emergency Medical Technicians.
Good afternoon. I'm David Owino, Maltesa International.
Good afternoon. My name is George Gadenya, CBM International, Christian Bride Mission.
Karibuni sana.
So, good afternoon, everyone. I'm Zainab Mohammed from the Kenya Red Cross Society Training Institute.
Welcome, Kenya Red Cross.
All protocols observed. Good afternoon. My name is Muna Mohammed from AfriPads.
Welcome.
My name is Susan Mumbua, Jacaranda Health.
Next table.
Good afternoon. My name is Susan Mwenesi from the New Africa.
Good afternoon. My name is Nanjini Amso. I write for Standard Media.
Good afternoon, everyone. Anastasia Mpungu from AAR Healthcare Kenya.
Karibu sana. Next table.
Good afternoon, John Kamau from BOC Kenya.
Welcome.
Hamjambo nyote.
Hatujambo, hatujui wewe.
Mimi ni sijambo. Jina langu ni Mbao Gitau from the Pharmaceutical Society of Kenya. Asanteni.
Good afternoon. My name is Chelagat Pauline Geshure from MedSource Group Limited. Thank you.
Good afternoon. I'm Dr. Nyango Michael from MedSource Group Limited. Thank you.
Pharma sector table huddling together there. Karibuni sana.
Good afternoon. I'm Stephanie Casella, Penda Health.
Good afternoon. My name is Anne Gumba from Africa Health Business. Thank you.
Good afternoon. Eva Mwai from North Star Alliance.
Good afternoon. Wamboe Kimani from the Kenya Association of Private Hospitals.
Wow. Karibuni sana CAF, Ponea Health, AHB, North Star.
Hello, good afternoon. I am Siddharth Ray, representing Technology Associates and Cranium Healthcare.
You're most welcome.
Good afternoon. Achocho Francis from Pract Health Consulting.
Karibu sana.
Good afternoon, everyone. I'm Rosemary Kinyanjui from Response Med.
Good afternoon, everyone. I'm George Capio from Imperial Medical Group, Santeni.
Good afternoon, everyone. My name is Dr. Ken Soy, representing Imperial Medical Group. Asante.
Karibuni sana.
Good afternoon, everyone. My name is Caroline Kawira from Kenya Private Sector Alliance, KEPSA.
Welcome, KEPSA.
Good afternoon, everyone. My name is Shadrach Darno from MediaMax.
You're most welcome.
Hi, everyone. My name is Matthew Ndeti, Commerce and Industry Magazine.
Good afternoon. My name is John Momo from Byte FM.
Good afternoon, everyone. My name is Fred Dongo. I work for Small Medium Enterprises Magazine. Thank you.
Karibu sana. I hope you can feature our meeting in your magazine.
Hey, good afternoon. Nyariro Agire from Ophthalmological Society of Kenya.
Karibuni sana.
Good afternoon. Onesmus Pesa from Good Life Pharmacy.
Hello, everyone. Daniel Karuma from Good Life Pharmacy.
A very warm welcome to Good Life. Are we done?
Good afternoon. My name is John Mwangi from Emergency Plus Medical Services, Kenya Red Cross.
Good afternoon. My name is Dr. Christine Memusi from Emergency Plus Medical Services, Kenya Red Cross.
You're most welcome to our members meeting. Next table is done. Thank you. Thank you very much. There's a table, there are people at the back who have not introduced themselves, right there at the back. Remember, we're waiting for our chief guest, Chief Administrative Secretary, Ministry of Health, Dr. Rashid Aman, and the head of the Kenya National Public Health Institute, Dr. Sultani Matendechera, who should be here shortly.
My name is Mary Gitari, and I'm here on behalf of Hydraulic.
Karibu Hydraulic.
Good afternoon. My name is Paul Karinkiti, and I'm here on behalf of Hydraulic.
Good afternoon. My name is Christina from Brandspark PR on behalf of Hydraulic.
Good afternoon. My name is Carol Mboya from Janst Healthcare on behalf of Hydraulic and Medela.
Good afternoon. I'm Sam Karaoke from Janst Healthcare. We are here for Hydraulic.
Good afternoon. My name is Liz Nyokabi from Janst Healthcare. I'm here for Hydraulic Pure Water Disinfectant.
Good afternoon. My name is James Biwott from Janst Healthcare, representing also Intersurgical.
Karibuni sana.
Good afternoon. My name is Faith Mudola from Janst Healthcare, representing Hydraulic.
Good afternoon. My name is Paris Nyambura from Janst Healthcare for Hydraulic.
Good afternoon, Marangu Moses from Kenya Healthcare Federation.
Good afternoon. My name is Dr. Brian Karaoke, Kenya Healthcare Federation.
Okay, I think we have one more.
Hi, good afternoon. My name is Dr. Sylvia Mwelu from Kenya Healthcare Federation.
Thank you, and thank you KHF team for putting this together in such an orderly way. You're all very welcome to this meeting, and the good news is serikali imefika. Serikal is here. And so it gives me great pleasure. I hope you've settled down a little bit. I'm calling you right when you've just got in. We have with us Dr. Sultani Matendechero. He's the head of the Kenya National Public Health Institute in Nairobi, Kenya. I think another way of understanding this institute, they're like a CDC, so they are our local CDC. And he will tell us how NTDs fit within the Kenya National Public Health Institute. Welcome, and you will also give us an overview of the NTD sector in Kenya and the MOH response. Karibu sana, Dr. Sultani. We're very honored to have you here. I did a little quiz before you came, just to prep the audience for your address. So they do know some hard names like Leishmaniasis, Schisto, somebody said Gigas. Which one is that? Bilharzia. I was really stuck on the Gigas. I didn't know it's an NTD. It doesn't sound very scientific, but I know where I come from. It really afflicts us. So we want to hear how we are covered, how the MOH is covering us. So a warm welcome to you.
All right, thank you very much, Dr. Daniela, and everyone else. Good afternoon. Yeah, as you can see, I've come in quite a bit of a rush because I was attending another meeting which I had underestimated, and it took much longer than I had expected. But this is very important, so I had to make sure that I come, and although I was running a bit late, I'm happy that I've been able to get here. So I had prepared some slides, but I think we can just talk about the neglected tropical diseases. And more specifically, we can be able to link them to what we are trying to set up in Kenya, which is the Kenya CDC. I'll talk about it shortly. So if you can allow me, maybe we can just have an engagement and we can be able to talk about this very important group of diseases, which we call neglected tropical diseases. Now, I also happen to be the immediate former head of the division of vector-borne and neglected tropical diseases. So as Dr. Daniela has correctly said, I should be able to take you through a little bit of that part. My colleague, Wycliffe Omondi, was supposed to be here, but there's another activity in West Pokot where he had to go and attend. So I'll probably also take this opportunity just to kind of speak to the neglected tropical diseases as well. So I think the first question that I need to answer is around what these neglected tropical diseases are. I think that's where we really have to begin. And I just want to say that this is a group of diseases. To be specific, there are 20 of them. And they actually, from the name, you can be able to deduce that they predominate within the tropics, within the tropical and subtropical regions of the world. For those of us who are very good at geography, we know where the tropicals are, the tropics. So they predominate in the tropics. And this is where you also find a lot of the third world countries. And so it brings to fore the issue that these diseases are closely linked to poverty. So these are diseases which affect the poor people, the poorest of the poor in the community. And you'll now be able to start understanding why they are neglected, because if these are diseases which affect the poor people, then we might not really be interested in investing in interventions for these kind of diseases. Because if you spend a lot of resources discovering, medicines and other technologies that will be required to control and eliminate these diseases, then your target population is not going to be able to afford these kind of technologies. So there is no return on investment. And so you'll find that scientists and researchers tend to keep off these kind of diseases. And so they continue ravaging the populations, and they continue predominating in these areas where poverty is also rife. And there is a vicious cycle that we end up seeing, because when a population is affected by the neglected tropical diseases, it makes them poorer, and the poverty makes the burden of NTDs worse. And so that is probably where I would just want to begin by saying that this group of 20 diseases, about 16 of them are endemic in Kenya. And maybe just to give some examples, we have the intestinal worms, which scientifically we call the soil-transmitted Elephantiasis. We also have bilharzia, which is very common in Kenya, in parts of Kenya, which in scientific terms we call schistosomiasis. We have trachoma, especially in the arid and semi-arid parts of the country. And we also have lymphatic filariasis, or which we commonly call elephantiasis, especially in the coast. And on we have visceral leishmaniasis, which probably some people know as Kala-Azar, and its variant, which affects the skin, which is called cutaneous leishmaniasis. And you can be able to see these are diseases that are found in the areas which are affected by poverty. There are others as well. We also have snake bites. And you'll find that people like us, we are very unlikely to be bitten by snakes, because in an area like this one, you'll not find snakes. These are conditions which will be found in the village. The young girl who's going to look for firewood, and then they step on a snake by mistake. The young boy who's taking care of cattle in the hot sun, and then they stumble over a snake, a black mamba, they bite. So you'll find that it affects the poor people more than the well-to-do, so to speak. We also have diseases like dengue fever, chikungunya, the list goes on and on. We have leprosy, guinea worm disease, cysticercosis, and so on, many others. There are others which are not found in Kenya, so we are not going to dwell on them. Now, these diseases are recognized by WHO. Somebody asked about jiggers. WHO also recognizes scabies and other ectoparasites as a neglected tropical disease. So jiggers are an ectoparasite, what we call tungiasis. So it is one of the neglected tropical diseases as well. So as I've said, about 16 of these diseases are found in Kenya. And so the Ministry of Health definitely has also subscribed to the global goal, which is to eliminate these diseases within our jurisdictions. So globally, the goal for WHO is to eliminate these neglected tropical diseases. Now, I'll pause a little bit because at this point, I would just like to zero in on the fact that some of these diseases are easier to eliminate than others. And in fact, there are some which, practically speaking, we might not be able to eliminate. And when I talk about these diseases, I think, bilharzia comes to mind. Bilharzia is found in the western part of the country, especially around the lake region. It is also found in the central part of the country, for those who are aware of the irrigation schemes in Mwea. There's quite a bit of bilharzia there. And then the eastern part of the country, Makueni, Kitui, Machakos. And again, the other high burden place is the coast, within the coastal counties of the country. Now, the bilharzia that we find in central Kenya, we can eliminate it. If we just put ourselves, our focus to it, it is something that we can be able to eliminate in Mwea, in those areas of the central part of the country. And so the same applies to the eastern part of the country and the coast. But when we look at the lake region, because freshwater bodies play an important role in the transmission of this disease, now it becomes very difficult for us to handle the effect of the lake because it's a very big freshwater body. And the snails that transmit bilharzia actually survive in that lake. So it would be impractical for us to think of elimination of bilharzia in the lake region. And so as a country, I am introducing the fact that for some of the diseases, our goal is going to be twofold. We want to eliminate these diseases where it is possible to eliminate them. But then where it is not possible to eliminate, we want to bring them under control. And I've just given the example of bilharzia. So in the lake region, we are looking at control as our goal, but in the other regions, we are looking at elimination. So why do we want to eliminate these diseases? It is because of what I just said. They exacerbate poverty, but at the same time, they also cause morbidities. Some of them actually cause deaths in our communities. And these poor people, when they are affected, they start thinking of witchcraft. Because they go to the hospital, they have schistosomiasis. And the doctor checks for malaria, negative. They check for typhoid, it's negative. At some point, they used to go further and check for brucellosis. They don't find it. And then they say, we cannot see your ailment. So when they come back home, they say, in fact, they've checked everything in the hospital and they have not found anything. So this one, it is my neighbor who has bewitched me. So witchcraft, as we know it in Africa, a big chunk of it is actually contributed to by the neglected tropical diseases. I'm happy to see my friend Sakwa here, whom we come from the same village with, and he'll tell you that in our home, we are capable of sending a snake to you so that it can bite you. Where I come from, we are capable of doing such things, So actually everything finds some kind of explanation in witchcraft so that we can be able to cope. That is a coping mechanism for our communities. So how do we think of reaching this elimination goal? I think I need to start looking at my watch so that, when I start talking about NTDs, I can speak for the whole day. So I really need to also time myself. So how are we thinking of achieving the elimination goal? There are 4 strategies. We have 4 strategic priorities that we actually look towards so that we can be able to eliminate these diseases. Number 1, we are looking at government ownership. Yeah? We are looking at government ownership so that the government can take up this particular task of elimination, so that the government is central to the elimination agenda. And when we talk of government ownership, we are also looking at issues like partnerships, because the government has to form a lot of partnerships. And the more the partners, the better. But we are talking about effective partnerships. Today we are here with the End Fund, who is one of our biggest partners in NTD control. We are here with the AMREF, a very big partner of ours in NTD control. I'm just looking around the room, and I'm saying that we need to increase the partnerships that we have if we are going to achieve elimination in this country. Now, when we have many partners on the table, then of course the issue of coordination comes in. So the first strategic priority is government ownership, being very strong, coordination and partnerships. The second strategic priority is around planning for results. We don't just want to go in without a plan. So we want to sit down and be able to say, within the next 5 years, what are we going to do? How are we going to do it? What are the resources that we need to be able to achieve this that we want to be able to do? So planning for results, resource mobilization, and financial sustainability. I will spare a few minutes of my time just to cycle back and talk about sustainability, because it is now becoming the most crucial element, when it comes to elimination of neglected tropical diseases. Sustainable control and elimination is a very important thing. So that's the second strategic priority. The third strategic priority is what we tend to pay most attention to, and that is access to interventions, treatment, and service delivery. So you'll find that we go out to a community that is affected by trachoma, and we check, we find that the prevalence is over 30%. And so we target everybody in that community. We give them mass treatment. Sometimes we go to communities which have a lot of intestinal worms, and we know that it is going to affect the capacity of children to go to school or maybe even to learn. So we target all the school children and we give them albendazole. We call it deworming. So this is mass treatment. We are making these interventions accessible. Sometimes we have neglected tropical diseases like lymphatic filariasis, which cause swelling of the scrotum. Yeah? And we can be able to correct that by surgery. We have seen people with testicles. The problem with us is we cannot really be able to use other names. Testicles which are so big, they weigh 50 kilos. Imagine somebody carrying 50 kilos of testicles because of lymphatic filariasis. They carry them on wheelbarrows if they have to leave the house. So these are people who are subjected, to the highest level of stigma in the society. Because the moment they leave the house, the first thing that people realize, or maybe they notice, is the testicles that they are trying to push on the wheelbarrow. Trachoma causing blindness. So we have to come in and conduct surgeries so that we correct that blindness that is being brought about by trachoma. And acute trachoma affects young children and women more than, mature men in the community. So that's the third strategic priority: access to interventions, treatment, and service delivery. There are 5 interventions, but I'll not go into that. So there is mass treatment, there is what we call intensified disease management, like the surgeries I've just talked about. There is provision of clean water, safe water, and sanitation and hygiene, as an intervention. We also have vector control, because diseases like Elephantiasis are spread by mosquitoes. So if we can be able to control the mosquitoes, then we are also able to control the disease. And then finally, we also have things like, because some of them affect animals as well. So we also have veterinary, the element of veterinary management of zoonotic diseases, because they affect animals and human beings at the same time. So 5 kinds of interventions that we use. But the fourth and last strategic priority is around monitoring, evaluation, surveillance, and research. Because we have to keep on finding better ways of dealing with these diseases. So we must conduct operational research. We must conduct scientific research so that we come up with better ways of handling these diseases. At the same time, we have to check, when we are starting the interventions, where are we starting from? What is our goal, our target? Within how long do we want to have eliminated? If it is 5 years, by year 3, where are we at? Are we moving towards our goal of elimination? Or are we moving away from our elimination goal? So monitoring, evaluation, surveillance, and research. So those 4 strategic priorities, if well implemented, and I know I'm speaking to potential partners who will come and work with us so that we can be able to move much faster towards elimination of these diseases. So you probably are looking at which is the main area that you can be able to fit in. If we implement those 4 strategic priorities well, then I can assure you that we will achieve our objective of elimination of most of the neglected tropical diseases. So, very quickly, I know that I was asked specifically to talk about the impact of neglected tropical diseases. I will not go into the details because the details will need a lot of time. But I just want to say one thing. If we now went back to the magic that I talked about, that we believe in as Africans, especially where I come from, and for some reason, magically, tomorrow we woke up and there is no neglected tropical disease in Kenya. Something that people say, voila, there is no NTD in Kenya. We would start saving immediately. We would start saving in excess of 200 billion Kenya shillings every year. And that is a very modest figure. We would save, we are wasting a lot of money. We are losing a lot of money, billions of dollars every year to neglected tropical diseases as a world. So imagine what we can do with 200 billion Kenya shillings a year. How many hospitals can we build? How many schools can we construct, for example? How many facilities can we improve? What would be the impact on the economy of the country if we are able to save those kind of resources, so that we don't just lose them to NTDs, but we channel them into productive activities that can be able to move our economy forward. On the flip side, the government is putting in a lot of money towards NTDs. And I'm happy to see Her Excellency, the First Lady of Kakamega here, because we are talking nicely to our colleagues at the county level to also put in a lot of money. But even unknowingly, we are putting in a lot of money every year because we are providing water, whether it is provided for irrigation. We know that if that water was not provided, then we would have a lot of trachoma in such areas, for example. We are employing health workers. For 8 years, I was the head of the division of vector-borne and neglected tropical diseases in Kenya. My salary was because when I wake up in the morning, I start looking at how we are going to eliminate NTDs. Today, Kenya is on the verge of eliminating lymphatic filariasis because of the partnerships that we have with the End Fund and others. If I would not have been paid that salary, if my colleagues would not have been paid, we would never be talking of elimination of lymphatic filariasis. That is money that the government is putting in. But the folly of it is that we are putting in more than $100 billion. If you look at it carefully, every day, not dollars, sorry, I'm thinking of dollars, shillings per year. And yet, we have a gap of just about 2 billion shillings, which is stopping us from moving towards actualizing our goal of elimination. So there are some pieces that we are not able to finance, which are much cheaper than what we are already financing, either directly or indirectly, which we just now need to put in, and we are able to move to where we are supposed to be. So that is food for thought in terms of impact of the NTDs. Of course, our children are not going to school, a good number of them. And even when they go, they are not able to concentrate. And so, some of these children who would have become engineers, they would have become lawyers, they would have become teachers, doctors, they are not able to realize their full potential because of something as simple as intestinal worms, interfering with their progress, with their ability, their capability to bring out their full potential. So the impact is very big. We don't have to belabor the point. And it is something that we need to start asking ourselves the hard questions so that we can be able to see how to move forward. Just want to recognize the arrival of our boss, the Deputy Minister, Chief Administrative Secretary, Ministry of Health, Dr. Rashid Aman. Welcome, sir. Now, very quickly, I just want to be able to link the neglected tropical diseases to the Kenya Centers for Disease Control and Prevention, that is the Kenya CDC. So, until recently, I was the head of the Division of Vector-Borne and Neglected Tropical Diseases, and now I am heading what we call the National Public Health Institute, which in other geographies like America, we call it CDC. So the America CDC is the National Public Health Institute for America. So, National Public Health Institutes are just institutions which are created to lead and coordinate public health functions in a country. Now, the control and elimination of neglected tropical diseases is a very important public health function. There are others like HIV, malaria, TB, disease surveillance, outbreaks, trying to make sure that you are prepared so that when the next outbreak comes, you are able to detect it as soon as possible so that you contain it at source without it spreading. And we are looking at countries being able to develop these public health institutes so that we can now create a network across the world. So that if, for example, a a virus like COVID-19 comes out in a place like Wuhan in China, we are able to put in a coordinated response. We support the management of that, response to that virus so that it doesn't spread to other geographies. Because eventually, COVID has taught us it is a problem not just to the country where it is coming from, but to the whole world. So NTDs have a very important place within this particular institute, which we are calling the Kenya CDC. And of course, as a ministry, we are very keen to see how do we leverage this new platform to move us faster towards the elimination goal. I just want to touch on 2 or 3 examples of how this expanded public health platform can bring efficiency. Number 1, we have a very rich pool of data which can help us to conduct surveillance and to respond to NTDs, to better control them wherever they are. And then, of course, we are able to coordinate our finances much better so that we can stretch the shilling and achieve much more for every investment that we make. So maybe as I conclude, I just want to say that for us here, who are here today, we have a big role to play in this goal that we are seeking to achieve. We also need to come in and see what is it we can be able to do. Because if we are talking of sustainable NTD programs, then we need to start moving away from over-reliance to external funding, because our NTD program currently depends so much on external funding for that gap that I talked about. We are already putting in so much, but there is that little gap that we need to be able to see. How can we fund it locally? So I'll not go into the details, but I'll tell you that it is something that is very possible, and it is something that we can be able to participate in, those of us who are seated here. You might not believe it, but the little contribution or the little part that you play is going to take us a long way towards being able to achieve the elimination objective. So I don't want to talk so much because I think I would like to hand it back to the moderator so that we can carry on with the next part of the agenda. But I also want to thank you so much for coming and for listening to me so that we can be able to talk about this important group of diseases which is really causing us a lot of havoc. Thank you very much, and God bless.
Thank you. Thank you very much, Dr. Sultani, for that overview. Sometimes we sit in Nairobi and we're very unaware of these diseases, but 200 billion shillings cost to us as a country is not small. And it definitely needs attention, and it doesn't happen by magic. We have to plan for results. That is what Dr. Sultani has told us. Now we'd like to hear about the role of governments in the control and elimination of NTDs, the Kakamega County experience, given by none other than Her Excellency, Mrs. Priscilla Ambetsa Oparanya, the First Lady of Kakamega County. Karibu sana, Your Excellency. We need the disinfectant.
Good afternoon, everybody. It's not easy to speak after an expert like Dr. Matendechero. He has summarized everything, but I will just read through my notes. The Chief Administrative Secretary, Dr. Rashid Aman, the Chair, Kenya Health Federation, Dr. Gakombe, Her Excellency First Lady Bungoma, Dr. Sultan Matendechero, Head of Institute, Public Health, Minister of Health, Dr. Carol Murutu, Vice President, End Fund, Dr. Mesha Kandung, Director, AMREF, Africa in Kenya, all the dignitaries present, all protocols observed, ladies and gentlemen. I'm delighted to be here today as the lead champion of intestinal worms and bilharzia in Kakamega County to give my thought in this very important forum. The Ministry of Health Division of Vector-borne and Neglected Tropical Diseases, in collaboration with AMREF Africa and the county government of Kakamega, is implementing a five-year program whose goal is elimination of intestinal worms, bilharzia in the county. The program is funded by End Fund and is aimed at interrupting transmission of intestinal worms and bilharzia through increasing coverage of mass administration, MDA, establishing effective collaboration between the NTDs and water, sanitation, and hygiene WASH sectors, implementing behavior change communication interventions. In the last 10 months, through collaboration with the Ministry of Health, national and county team, and AMREF, high-level advocacy meetings both at national and county level, have helped in improving coordination and partnership, resulting in the establishment of county neglected tropical diseases champions, spearheaded by county first ladies. As a champion, my main role has been to engage key policymakers, including county leadership, health budget committee, and county health management committee, prioritize NTDs, and more importantly, intestinal worms and bilharzia control and elimination of interventions in the county. To ensure my community know about the intestinal worms and how they spread and what we can do as a community to prevent them and break the life cycle through different platforms, including radio talk shows, public forums, and workshops. Engage the county leadership in influence allocation of health budget to help address the intestinal worms and bilharzia in the county, which is an important public health problem in our county, as they cause malnutrition, anemia, and retardation of physical growth, cognitive development. Among at-risk populations include preschool children, which Dr. Matende talked about, and school-going children, even elder people in our community. Through the advocacy efforts, the county government of Kakamega has allocated 25 million shillings in this year's health budget to procure drugs that will be used to treat intestinal worms in antenatal clinics. Last month, we just concluded intestinal worms and bilharzia survey to establish the burden of the two diseases in the county. It is our hope that based on the findings, we shall be able to give communities medication to help in treatment of the diseases. In elimination and control of these diseases will not only keep children in school will not only keep children in school, giving them enhanced economic capacities for their future, but will also ensure the reduction of out-of-pocket expenditure in health, which can be additional burden of the affected families. As the county government, we continue to hold consultation meetings at the county level with the governors, CECs for health and their teams, county assembly, and other key players in the health sector on the importance of investing in the control and elimination of NTDs, as well as enhanced WASH interventions to sustain the gains made. Further, there will be concerted efforts to seize every opportunity like this, Kenya Health Care Federation, to advocate for increased funding, prioritization of NTDs, to attain the 2030 global targets for soil-transmitted Elephantiasis and bilharzia. I take this opportunity to applaud AMREF and END Fund for working closely with the Ministry of Health stakeholders to strengthen health systems that holistically address various health challenges, including NTDs. Thank you very much. Thank you very much to have invited us to join you in this very important forum. And maybe just before I leave the podium, I'm just wondering, Kenya Health Federation, Kenya Healthcare Federation, unfortunately, I've heard about you today, and I was just wondering where you have been, because county first ladies, we are tasked to take care of health matters in our respective counties, and we have a very strong association. We have partnered with quite a number of stakeholders. We have partnered with AMREF, and we have walked along the journey. So I was just requesting that maybe you come and at least if we can partner with you so that we take care of health matters in our respective counties. With me, I have our organizing secretary, First Lady Bugoma County. I think she can talk more about our association. Thank you very much, and may God bless you.
Thank you. Challenge accepted. I think after this, through the chair of KHF, we better make a plan to engage with the Association of County First Ladies. But thank you very much, Mrs. Oparanya, for those remarks and giving us the Kakamega County experience in terms of combating NTDs. And now it's my pleasure to welcome Her Excellency, the First Lady of Bungoma County, Ms. Caroline Wakamati. Karibu sana. Please give your remarks and your perspective. Give her a clap as she comes.
Good afternoon, everyone. I'm not as tall as Dr. Matendechero, so I hope you can all see me. This is Caroline Wangamati. I have the honor to serve as First Lady Bungoma County. I want to recognize our CAS, Dr. Rashid. We came to your office. I applaud the work that you do, and I'd like to remind you that you have a heritage from Bungoma County. We took you through your ECD classes. So when I speak, just know that I'm very sentimental and I know I'm addressing somebody that has Bungoma interests at heart. I want to recognize the partners in the room. AMREF are a favorite. I've done a lot of work with them in my county. And Fandio here. And Dr. Wala, allow me to mention you because for a long time, all the work that I did in AMREF, you're the person that I worked with. And I thank you for that. And congratulations on where you are. Dr. Matendechero, you have a very complicated name, but I mastered it because I also come from those regions. And yes, we do send snakes to people, but we're not sending any snake to anyone in this room today because we are addressing the issue of neglected tropical diseases. Bungoma County happens to be one of those counties that has a very heavy disease burden, and it cuts across the board. Whether you're talking about the neglected tropical diseases, whether you're talking about the gynecological issues for women, whether you're talking about general surgery issues for, men and women, whether you're talking about maternal mortalities, whether you're talking about neonatal mortalities, we are one of those counties that does feel the burden of health within our population. And taking the lead from my sister, I think we are the third most populous county in this country, yet most of our people are very poor. And for that reason, just as it's been eloquently put here, there are diseases that follow the poor. And I think it is very unfortunate when you actually interact with these communities and you see what they go through. One of the privileges of serving as a First Lady is you come face to face with these problems. We can sit in a Movenpick hotel and look very healthy and enjoy the good food and everything that we have here and look healthy. But I can tell you, my good people, you have no idea what this country looks like until you walk out there with our people, until you go to the homes of some of these people and you see the conditions that afflict them. And I can tell you for a fact, and my sister here will testify because she's my senior, she has served for 2 terms, I am only a first-timer, that the burden of disease in this country is so heavy. And we need every single person, whether it is private sector, whether it is government, whether it is you as an individual, to do something to help the people of Kenya, to do something to help that poor person that you never even think about when you're sitting in your house. Until the day when I went to Kisumu for this program, and I want to thank AMREF and Fund and Ministry of Health, because you made me aware that some of the problems I've been working so hard to eliminate, I've actually been approaching it the wrong way as a First Lady. I tend to do blood drives. I'm very passionate about the issue of blood because in this country, as you know very well, we only collect about 30 to 40% of the blood that we need. And when I go to visit the mothers in our hospital, I like to study the charts. And I found that in one of my sub-counties, over 50% of the women that are presenting for the first ANC are anemic. I happen to be born in that same sub-county, and every time I've tried to do blood donation, apart from the perennial problem of never achieving the 50 kilos, which I don't know how to address it because I eat a lot of chicken, my HB has never gotten to where it's supposed to be. And until I went to that workshop in Kisumu, that is the time it actually occurred to me that I could be one of the people who are suffering from worms, and I have no idea. I assure you, as you're seated in this room today, quite a number of you are suspects like myself. You're sitting here with worms in your system that are afflicting you, but you're thinking you're okay. You meet children. When I go to the pediatric hospital in Bungoma County Referral Hospital, the biggest problem that presents is anemia. And all along, I thought it is malaria. All along, I thought it is sickle cell. And all along, I thought it is malnutrition. Until Dr. Matende Chiro educated me, and I got to learn that actually worms might be the biggest culprit we are dealing with, and I had no idea. So I assure you, when I stand here today and I speak as a champion of the NTDs, I know exactly what I'm talking about. Because we watch those children succumb. We watch those mothers succumb. We watch those men and women be reduced in terms of their social economic impact because of something that we can do something about. And Caroline and Fund, you're doing an amazing job. And I want you to not tire. And you're speaking to the right people today, because Kenya Healthcare Federation are the private sector. And Dr. Nyalita here will tell you, Dr. Gombe, you weren't in office then, but Caroline is here, Caroline Kawera. I actually got a chance to be an intern at KEPSA. While I'm doing some studies, I'm trying to become an expert. You know, I'll never be a Dr. Matende Chiro, but I'll be something like 10% of what he is. So I got an internship, and I know the power that KHF have. I know the power they can mobilize for you. And I think, Caroline, you've done well to partner with this team. These are people that will support you. These are people that understand the problems that are there in this country. But I want to throw the same challenge that my sister threw to KHF. Why don't you come to the counties? Why don't you speak to us in the counties? Nairobi life looks very rosy. When you sit in Movenpick, you even have no clue what's happening elsewhere. But I can tell you, if you ask the CS Rashid, he'll tell you, Bungoma has problems. Kilifi has problems. Mombasa has problems. Busia has problems. Kilifi has problems. Why don't we do some of these interactions where the problems are, so that we speak while we look at the problem? I want to challenge you, and I like to be very selfish and say, come to Bungoma County. My sister is here, and I know she'll say, come to Kakamega, but come to Bungoma County, and I'll take you around to the villages. I just did a camp 2 weeks ago, where I was operating on women with a condition called obstetric fistula, and third and fourth degree tears. And Dr. Meshak is here. Amref, who are a very big supporter, worked with the UNFPA, worked with the M-Pesa Foundation. And all along those partners, when I was telling them we have a burden in Bungoma County, they thought I'm just a loud girl. Until they came. We budgeted to operate on 50 women. We operated 57 women, and we left 40 women with a problem whom we did not address. And we're looking for money now to go and run another camp to actually repair those women. Fistula is another disease that is neglected. Fistula is another disease of the poor woman. And I can tell you guys for a fact, unless we start thinking of those people who are disadvantaged within our communities, we are not serving this country right. And MOH will not do it alone. Dr. Rashid is a very passionate man. I have been to his office and presented a very long list of Bungoma problems. I do hope you remember, sir, because I'll still be coming back to you to ask you of the same. But today I'll spare you because you're here to talk about the intestinal worms, the neglected tropical diseases. So we shall focus there. So personally, I am ready to take this message out. My team is here, and my team is ready. We are people who love to deal with the community. We don't like to sit in our office. If you came to our office, you'll never find us in the office. But if you went to Bumula, in a small village where people are affected by jiggers, you'll find us there. If you went to Mount Elgon to find the women affected by FGM, you'll find us there. If you went to Tongaren to find the woman who walks 5 kilometers to access the nearest health facility, that is where you'll find us. And my team, I want to challenge you today. At Bungoma County, we have always been very good at doing these things. I want you guys to be the ones. We are only 4 counties where this program is running. I want you guys to make Caroline here proud. Let her know that the money she has mobilized to come and clear these diseases in our county does not go to waste. Because this is a disease that we can eliminate. You're the ones who see the babies succumbing in our hospitals, so you know exactly what I'm talking about. As I finish, Dr. Matendechero, we finally have a Kenyan CDC. And I think that is one of the proudest things we've done as a country. Kenya is always a pioneer. Kenya has always led the way. I don't like to talk about South Africa. Let me not talk about South Africa. But in sub-Saharan Africa, I think we always lead. And I think I'm looking forward to see some of the things that you're going to do. And just like in Kisumu, I want to throw a challenge to you, that I want you to think about sickle cell disease. Imagine a child who is already affected by somebody who is a sickler, and then they get the intestinal worms. What are the chances of that person even surviving? 50% of sicklers are dying at 5 years. With this problem of NTDs, I am sure they're dying even before 1 year. As a CDC, let us find some intervention for the sicklers. I like to tell, and I told Dr. Wala so many times, and Dr. Meshak, probably you never knew this. I kept asking the question that we talk about malaria mortalities in this country. To what extent are those mortalities being precipitated by sickle cell disease? It is another neglected tropical disease. And I want to throw that challenge to you, that we think about it as a CDC and we see what we can do about it. Closing remark, County First Ladies Association was formed when we only had male governors. So it is for the ladies. But I know very soon, because my sister here might become governor of Kakamega very soon, we will need to change that a bit. But we have an association that is competent, that is led by very well-schooled ladies, very eloquent ladies, great advocates. I request everybody sitting in this room, whether it is MOH, whether it is an N fund, whether it's KHF, come and talk to us. I'm an example of what you have there, so you shouldn't be worried. Let us engage with one single aim, a singular aim, to help the people of Kenya, those who can never stand here and speak for themselves. That is our role, and I welcome you to join us there. Thank you so much. I thank you for this opportunity, and I look forward to working together. God bless you all.
Let's give her another hand as we think about the challenges that she has posed our way. Wow, it's difficult to link to the next thing after that very, very captivating challenge from our First Lady of Bungoma County. At this point, we continue with our conversation about neglected tropical diseases. I would like to invite Dr. Carol Karutu, who is the End Fund Vice President in charge of programs, and she'll speak to us on why African participation and leadership matters in order to tackle NTDs. Karibu sana, Dr. Karutu.
Thank you, Daniela. Dr. Rashid, Chief Administrative Secretary, the First Ladies, Priscilla Oparanya from Kakamega County, Caroline from Bungoma County, Dr. Gakombe, KHF, our Chairman, Dr. Sultani, our former Program Manager and now Head of Kenya CDC, Dr. Nyalita, CEO, KHF, Dr. Meshak from Country Director, AMREF, all protocol observed. It's really my great pleasure to be here to talk to you about NTDs. Okay, let's move. So I'll start by telling you a little bit about the N Fund. The N Fund work is centered on 5 neglected tropical diseases, and these have been mentioned. 2 of these have been spoken a lot about today. That is schistosomiasis or bilharzia, soil-transmitted helminths that we popularly know in Kiswahili as minyoo. We also work on river blindness, elephantiasis, and trachoma. These diseases, as I stand here today, affect 1 billion people. And many of these people are in the African continent. And this is why we are here, because as Africans, as Kenyans, we need to begin to think a little bit more about what we can do to address neglected tropical diseases. As very well articulated by the First Lady of Bungoma. Next slide, please. And next slide. These diseases cut across our economy, our education sector. As you can see, they affect nutrition of the children. We very much heard about anemia. We've heard about absenteeism in schools, but we've also heard a lot about the economy. They reduce productivity, such that today a kid who is dewormed is at a better place 20 years today, or being more productive than one who is not. Next slide, please. And so the End Fund has been in Kenya since 2014 or thereabout. Through this time, as you can see here, we've invested over $11 million. You can multiply that by 100 to get the Kenya shillings. And then we've covered about 35 million treatments. And that's treatments across soil-transmitted helminths, bilharzia, and elephantiasis. At the same time, we've helped a lot train the healthcare workers, because if we don't train healthcare workers, then we don't have the sustainability that we need to address these diseases. Next slide. Now, why are we here today? In April of this year, the UK government, their development arm, commonly known as FCDO, cut funding for development. And in particular, they cut 100% of their funding for neglected tropical diseases. So programs that were planned for this year in many of the countries in Africa and very few countries in Asia actually got affected. And it's at the blink of an eye. Everybody thought the program was continuing, and then suddenly the UK government says, no, this is it. We are not funding neglected tropical diseases. That meant countries like ours, where drugs that are so generously donated by pharmaceutical companies were in stores and were likely to expire. And our government, as well as us, the private sector or the NGOs, we did not have a plan. At the same time, we had backlog of hydrocele surgeries, not just in Kenya but elsewhere, to be conducted this year. Again, we did not have a plan. You've heard from Dr. Sultani what it means to have hydrocele. So that person who was so looking forward to having that surgery, suddenly, at the blink of an eye, cannot get that surgery done anymore. So at the End Fund, we thought, what can we do? What is missing? And we realized it is really a lack of preparedness, not just as an organization, but also ourselves as the Africans who carry 75% of this NTD burden. And so in June, we had a workshop. It was a webinar, remote, virtual. Next slide. And what we did was bring together African leaders from government, academia, private sector, to have a conversation. And have a conversation asking ourselves one question: what can we do as Africans? What can we do as Kenyans? Because we do not want to be caught next time a foreign government decides, I am not funding this disease anymore. And so we've begun this movement, which you are part of today, to really advocate for neglected tropical diseases in a small way. What can you do as the private sector? What can I do in my role? And what can the county government do? What can the national government do? Now, as you see from here, this is where we started many years ago before mass drug administration. Dr. Sultani talked about the many kilos that somebody with hydrocele carries. You can see it right there. You can see those worms in that jar. Those worms are from a child's belly. You can see that woman there. She's blind. If we do not have the surgery that costs very little money, as you'll see in my next slides, then she or he goes blind. So this is where we were. But where are we today? Next slide. Children are happy because they're getting dewormed twice a year in many countries, or once a year, because of the generosity that I spoke about from external donors, but also the generous donation of drugs from the pharmaceutical companies. Our government has also, as very well articulated by Dr. Sultani, put in quite a bit in helping, making sure that the mass drug administration is successful. Our county first ladies are actually going to lead one very soon, one mass drug administration in their counties in November. So this is where we are today. We are happy. The children are happy. The women in the rice fields are happy. However, this can be short-lived, and we can go back to what you just saw in the previous slide. So, goes back to the next question. Next slide. Next slide, please. Next slide, please. So, the question is, what can we do now? And even more important, as the private sector, as a government, why should we care and why should we invest in NTDs? The first thing that I must speak about, being the private sector, NTDs is great value for money. Investing in NTDs is great, great value for money. As you can see there, 50 cents, which is equivalent of 50 shillings, can help deworm a child today. We make that deworming, and Dr. Sultani will tell us it's one round for that one child. So if you have 1,000 shillings in your pocket today, in your company, that is 500 children dewormed today. So we cannot say, I don't have enough. I think those of us sitting in this room, we can all afford 1,000 shillings or even more to actually deworm the children. So it's a great value for money in terms of cost. Number two is, I talked about the trachoma surgeries. A trachoma surgery today is about $100. In Kenya shillings, that's 10,000 shillings. By having that surgery, you save someone, you avert blindness. And economic productivity, this person can continue to feed their family, which they wouldn't if they went blind. Again, children that are dewormed are 25% more likely to attend school than if they're not. And we all know that. We've all, those of us my age and older, and went to school sometime in a village, you know what having wands means. Somebody, you have your classmate and they're dozing next to you, next day they don't come to school, and finally you're here and they're not. And then it's very, with NTDs, the integration touch points, by improving water hygiene and sanitation, we get NTDs integrated there. Education sector, I talked about that, and I also talked about the veterinary sector. Next slide, please. Next slide. And then, in terms of the previous economic benefits, there's a study actually that was done here in Kenya, and it showed that for those children that were dewormed, those adults now that were dewormed many years ago, 10 or so years ago, their economic productivity increased by $27 to $42. So $2,700 to $4,200. That is really great value when you think about economic productivity. That means someone can buy their unga for that amount, even more than unga. They can shop for the entire household that particular month with that amount of money and still afford to take someone to school. So that's a really big value add economically when you think about it. And then again, we are thinking about elimination. These diseases can be eliminated in our lifetime. That is the beauty of it all. So we put in the money that we do now, we put in our thoughts, our networks, our family contacts, and we can actually eliminate NTDs. So as I conclude, next slide. My call to you today is that together, as the Kenyan government, the county government, individuals, private sector, and also our friends in the diaspora, our international colleagues, we can together end NTDs. However, it has to start from us. It has to start from us, the Kenyan people, to eliminate NTDs to want to eliminate NTDs for our population. Thank you very much.
Thank you very much, Dr. Karutu. Now we know what end fund is. We know what end is. It is end neglected tropical diseases. And at this point, I also want to recognize our members who are joining us online. They are following closely online. Karibuni sana, those joining us online. We have about 36 people online. And now I'd like to welcome our chair, Dr. Gakombe, so that he can welcome our chief guest. That one is sanitized.
Good afternoon, ladies and gentlemen. In the few seconds that are allowed to me, please allow me to dispense with all protocols, and you forgive me. Our CAS is constrained for time, and as you know, COVID taught us that there is an army, and that army is the health force, and General Rashid is a major part of that army. And like all armies at war, there is very little time to do much else except be on the war front. And we are still on the war front. We have made progress against COVID. We want to acknowledge that fact and thank the ministry for providing us leadership in getting COVID to where it is at this time, and to remind each of us that we still have a great responsibility to work hard to take COVID to not back to where it came from, but to control it and eliminate it. So, Buenas CS Rashid, karibu sana. Thank you for gracing this occasion. We are a partnership for healthcare, and by bringing all of you into this room, we have accomplished our objective as a Kenya Healthcare Federation. So please join me in welcoming one of the key leaders in our Ministry of Health and the health sector. Karibu sana.
Thank you very much, Dr. Kombe. I want to recognize and acknowledge their excellencies, Priscilla Oparanya of Kakamega and Caroline Wangamati of Bungoma, Ms. Carol Karuti, End Fund, Dr. Meshak of AMREF, the Chair, Dr. Gakombe of KHF, Ministry of Health officials, county officials, distinguished participants, ladies and gentlemen, good afternoon. Let me start by reassuring their excellencies that, yes, indeed, I do have a special connection to both your counties. My very early education was in Bungoma County when I was a very small child. And I spent a good part of my growing up life in Kakamega, where I have family. So I think your interests are taken care of. Yeah? This particular topic of neglected tropical diseases is a subject that is close to me because I've spent many years of my career as a scientist working on some of these diseases. They are neglected for a particular reason. Maybe they're not very appealing. They don't have the numbers that, grab people's attention. But the fact is that these are very serious diseases, very debilitating diseases, disfiguring diseases that make life very difficult for those who are afflicted. And I think as a society, even if they are orphan diseases, as some may call them, we need to pay attention and we need to do what we can to alleviate the suffering of those who are afflicted by these diseases. It gives me great pleasure to join this Kenya Healthcare Federation convened private sector consultative meeting on a sustainable and locally driven movement to end neglected tropical diseases. I think the idea and the theme of this meeting really is to tell ourselves that there are certain things we can do. And if we get together, we can do it. I've often wondered why, as a society in Kenya today, we have a fairly good economy. We have some world-class corporations, Kenyan corporations, in this country. We have a private sector, I think, that is willing and passionate about doing something for society. Why is it that we cannot develop a philanthropy culture? I think we can, but we need voices out there. We need people to challenge those who are able to do so, to do something. And that's why I think this meeting and the fact that the private sector, led by KHF, has taken this initiative is important, and I want to encourage you to continue with this push. It's going to be hard to get people to be convinced to put their money into some of the programs that we are thinking about. But I think it can be done, and I believe we can become a country that is able to fund some of our activities through philanthropy. As I speak to you today, more than 25 million Kenyans require treatment for one or more of the NTDs that we have talked about today. These diseases are endemic across the country, and they primarily affect the rural poor communities where there is low access to sanitation and clean water and limited or no access at all to quality and affordable health services. The Ministry of Health is committed to the expeditious elimination of NTDs in Kenya. This commitment is aligned with the provisions of the World Health Organization NTD Roadmap 2021-2030. To this end, the government, through the Ministry of Health, has continued to strengthen access and delivery of interventions to counter the impact of these diseases that debilitate, disfigure, and even kill. Over the last 10 years, the national government has provided stewardship in the control and elimination of NTDs by developing policies and strategic plans to guide achievements of set targets. In 2021, Kenya became the first nation in Africa to launch a 5-year 2011-2015 National Strategic Plan for the integrated control of neglected tropical diseases. This was succeeded by the second plan, 2016 to 2020, and I understand we are in the process of developing the third 5-year strategic plan. In line with actualizing objectives of these plans, the ministry has continually provided both capacity building and technical assistance to the counties as stipulated by our 2010 Constitution. These endeavors have resulted in progressive upscaling of NTDs interventions in the last 10 years. Allow me to highlight some of the key achievements made during this period. In 2018, the country was certified free of guinea worm by the World Health Organization. That was a milestone. Sustained vector control and chemotherapy have suppressed the conditions of onchocerciasis, commonly river blindness, and human African trypanosomiasis, or sleeping sickness, such that they are no longer of public health importance in Kenya, and we are on track to be validated free of these infections. Cases of rabies and leprosy have also significantly reduced in the country. We are also on track towards the elimination of trachoma and lymphatic filariasis, thanks to our sustained efforts of mass provision of free preventive chemotherapy medicines to those affected. Last but not least, we have equally gained impressive traction towards control and elimination of bilharzia and intestinal worms in key endemic regions in the country. Many factors have contributed to the above control and elimination successes. But the big and main factor is government ownership and leadership. This is critical. I think even going forward, it is going to become even more critical as we begin to look at how we are going to fund it ourselves. Government, I mean both the national government as well as the county governments. The ministry has been in the forefront in embracing and domesticating global strategies to deliver its targets. For instance, Kenya was one of the first countries to adopt lymphatic filariasis triple therapy, which has accelerated elimination of this disease because of the cut down in the period of treatment from 5 years to 2 years. We have shown this in 3 sub-counties in the coastal region. Building on these achievements, it's our aspiration and determination to cascade ownership of programs such as this one, the NTD program, to county levels, as stipulated in our 2010 Constitution. We are in a country that has devolved system of government, and health is one of the areas that is fully devolved. So we expect that as we move forward, the burden of actually carrying out these operations and programs will fall on the counties as we at the national government provide you with the technical support, capacity building, and the right policy direction to achieve our goals. Coupled with government ownership, partnerships and collaborations with stakeholders is another reason for our successes that have given impetus to the strategy of elimination of NTDs in the country. The ministry continues and will continue to collaborate with all well-wishers, global and local partners, and these include several, including the World Health Organization, donor countries, private philanthropy, research institutions, NGOs, civil society, community organizations, and others. The need to expand this partnership to include local and in-county private players is crucial towards self-reliance and attainment of the UN SDGs and the aspirations endorsed by the member states in the WHO NTD 2021-2030 roadmap. Despite the progress that we have made, obstacles still exist and will appear from time to time in this journey of ours of freeing our nation from NTDs. Some of the obstacles that stand in our way include gaps in our knowledge on distribution of some of these NTDs in the country, the re-emergence and surges of vector-borne NTDs such as dengue, chikungunya, and leishmaniasis. This may be triggered by events such as climate change and low suspicion index and awareness of NTDs. As you are aware, NTDs mainly affect the poor, the majority of who live in rural areas. In some quarters, NTDs continue to receive little attention, in spite of the fact that interventions are available and can be delivered to affected people and communities in simple ways, safely, and at low cost. Which is why we must keep this conversation alive, because this agenda can slip off the table anytime, and the stronger the voices that come out from fora such as this, it keeps this discussion alive. Sustainability, which was talked about here, and moving towards self-reliance are critical if we are to manageably control or better eliminate NTDs in our settings. I think Caroline alluded to the fact of the foreign aid cutbacks in April 2021 by the UK FCDO, which resulted in the winding up of the operations of its flagship, accelerating the sustainable control and elimination of neglected tropical diseases, or the ASCEND program, a decision that seriously affected NTD control, elimination, and eradication programs in 19 countries, including Kenya. The impact of these cuts meant that over 100 million people across 22 countries were at risk of not receiving life-changing NTD treatments. Closer home in Kenya, specifically, more than 3.2 million people would miss a round of mass drug administration for schistosomiasis. 300,000 individuals in need of hydrocele surgeries would miss this life-changing surgical procedure, and 2,760 individuals would miss out on morbidity management and disability prevention interventions. This, in addition to the risk of expiry of donated drugs worth millions of shillings already in the country. As a country, we cannot sustain control and elimination of NTDs with continued over-reliance on external funding. Deliberate efforts must be made to refocus on local funding. We must move away from the silo approach by strengthening integration of NTD control activities to optimize utilization of currently available scarce resources for maximum impact. I think before devolution, we had a very strong structure of public health system and public health officers. Your Excellencies, I think you will agree with me that we have had some challenges in that area with devolution, and I believe that is an area I would want you to champion, to see how we can reinvigorate the public health systems on the ground. How can we ride on a good public health system to address many things at the same time? This is what we're saying, that this is how we can use little money to achieve much, much more, stretching the shilling, so to speak. So I think we need to work together to build that system and to see how we can stretch that. I'm aware in the counties that you come from, Your Excellencies, both Bungoma and Kakamega, that we are now actually talking about a program of malaria vector control by spraying the larvicides, a technology that we have brought from Cuba, which is about to take place very soon in 8 endemic counties. These are the kind of opportunities that we need to use to see how can we piggyback other activities on a program like that, that will have a lot of field work to address some of the other challenges that we have. I think you will certainly go and look back into this program and see how you can work within this program to do some of the other things that we're talking about here. I welcome your collaboration to create awareness and raise domestic resources towards ending these diseases that are preventable or treatable. So it is in our power to end neglected tropical diseases. With this momentum within the country, I believe we now have reached a high point towards the control and elimination of these diseases. Your involvement will, among other things, increase awareness and uptake of NTD interventions to affected community members, complement funding from governments and donors to control and eliminate endemic NTDs, and ultimately co-create sustainable local health systems, strengthening solutions that enhance transition plans that aspire towards eventual self-financing, independence, and meaningful long-term project impacts. As we look towards this robust domestic resource mobilization, through your support, by emphasizing that Kenyan leaders from all walks, public, private sector, civic society, have the opportunity to be effective NTD champions and advocates by using their influence to facilitate an increase in domestic financing at regional, national, and local levels. I would like to assure you that the funding channels to be realized will be aligned and harmonized around program goals and priorities through better accountability and transparency tools. As I conclude, I wish to recognize and acknowledge the contributions and commitments we have received from WHO, various pharmaceutical firms, experts, academic and research institutions, international donors, and local implementing partners towards the reduction of the burden of NTDs in our country. With the envisaged plan, we're set towards making NTDs history in Kenya. I believe that this meeting will be a strong platform to help us make progress in this direction. I thank you all for your attention.
Our chief guest, kindly remain on stage as you're joined by Your Excellencies, the First Ladies. Please join Kas Rashid for a photo opportunity. Dr. Sultani, Dr. Karutu, Dr. Meshak, our board members, our chair. Let's just have a photo opportunity before our chief guest leaves us. Also, our sponsors of the event, JANST and MSP. Yes, all of us in one quick photograph. Thank you. And don't talk. Thank you all. We'll allow our guests now to leave the stage. But she's telling us what next. She's telling us what next. Yeah. What next? Dr. Karutu, I think you're remaining on stage for what next? Having heard from our policy makers, having heard from the county governments, from the partners, what next? Your mic is coming. I might have to move around with you now if she's going to ask.
Okay, I can go back, that's fine. All right. So this session is quite short, but we wanted to get your input on where we go from here. You've heard what we've had to say today from the government, both at national level and county level, the Ministry of Health, ourselves as an NGO. So the question is, as a private sector, where do we go from here? And that's the question that we throw to you. How do you, at a personal level, as your company, as your family, help in eliminating and controlling neglected tropical diseases? So this is open discussion, and Daniela and team will move the mic to the different tables.
So members, if you have a comment, and we do have one, please, from Her Excellency.
Yes, I think where we go from here, first we have to create awareness that intestinal worms can cause damage to the health of individual, because we assume so much, maybe some parents don't know. They just feel, my son has a big stomach, maybe has overeaten, without considering that this could be worms. Once we get the information, once they get the information, I'm sure parents cannot miss to afford a drug of 50 bob to give to their children. First, let us create awareness, and then the rest will follow. Thank you.
Thank you. That's from Her Excellency, Madam Priscilla, creating awareness. So again, where do we go from here? Dr. Gakombe. And then I'll go to you, Anastasia.
There are quite a number of things we can do, and yes, it starts with awareness so that those afflicted don't take it as normal. For the private sector, it would be very helpful if there are tax incentives for those who wish to give resources to these and other causes. And I think part of what counties should do is probably to have county charities officially registered, tax exempt, so that if I give my money to support a cause, I don't then pay tax on it. Secondly, we are all contributing to NHIF. I think part of the money we give should be, there is money that should be earmarked for certain community engagements, and that to me is certainly better than helping hospitals buy equipment, because the impact is right at community level. Then when I was growing up, because these things were there, the school system was very effective in creating awareness and being points of engagement and intervention. I am not sure how much coordination there is today between the Ministry of Education and the ministry and those of us in health, but schools do provide a key focal point for reaching out to, especially to children, and it's something we should seriously look at. Finally, KEPI has worked well by using everybody as a means to reach the population. We all vaccinate at very, very nominal fee because we get the vaccines free. There is no reason why private sector facilities should not also become key centers for deworming and other interventions that are required. Thank you.
Thank you, Dr. Gakombe. Anastasia, where do we go from here?
Thank you. Two things. The first one is, of course, I believe we have very low-hanging fruits. I mean, I cannot imagine why we are using bonga points, which most people don't even really, whatever, to buy stuff. And why can we not mobilize that into some sort of funding? So we need to have a structured funding mechanism. That one, like my director Vinod and my chair says, incentivizes the private sector to put in funds, which means I put in funds, I have some tax incentive. But more important also for the general community that either have bunker points or even, for example, the corporates will have that. How can I monetize that? Is there a structured place where that can go in? And this fund, people know that it is supposed to be put, to go to some good use. I think that's a very, I mean, if you look at Nakumat, by the time, it closed down, a lot of people still had a lot of points they had not utilized. So let's see how we can use such low-hanging fruits, but in a very formal way, some form of policy of some kind, with the blessings of the government, and I know KEPSA is here, they can support us in that initiative, to look beyond health sector, to mobilize all those resources. The resources are there, but also very important is also to get the communities to own the problem so that they know it is a problem, it is solvable, and this is where I can go when I have this. So that structured approach, which is written down and agreed by stakeholders, that will be important. Thank you.
You mentioned KEPSA, and there's somebody, one of our stakeholders that I don't know, could speak first, and then if KEPSA is in the room, would also like to hear, right behind Anastasia. If KEPSA could also tell us where they think we can go from here. They are very important constituents.
Yeah, hi. We became a member of KHF recently, but we have been into the healthcare industry for almost more than a decade. All the things that we have been hearing about and people have been talking around in this room has data behind it. It's data driven. If you're talking about funding, the funders would want to know the data. If we want to distribute medicines, we need data. And how do we collect those data? Because most of the facilities in the county level are still manual. They're not collecting data. Even if the data is collected, it's not clean. And how are we analyzing those data? Nowhere. There is a possibility in where the private sector comes in, is how they can help streamline in collecting those data, cleaning those data, and then by helping the government level in the ministry level to mine those data, right? So that would be one of the what do you call, a play that can be played by the private sector.
Thank you. KEPSA, is KEPSA in the room? There's, yes, somebody, I think George over here.
Yes, thank you for giving me the opportunity. My name is George Gadenya, representing Christian Bright Mission. One of the biggest challenge is many people would like to help, but in many cases you find that people may not and consultation, we are now working together with the Ministry of Education in Kiambu, in Kajiado, in Meru, in Bomet, Vihiga, and Kore counties to move the screening of the cases from the health facility to the schools, so that then we can have 100% screening of the children. If we can take a similar initiatives for the intervention that are needed in neglected tropical diseases, then we can be able to move a higher level. Thank you very much.
Thank you, George. I see, yes, one more person there.
Thank you, Caroline Kawira from KEPSA. Just to mention that KEPSA being the apex of the private sector in the country, we have a unique convening power where we have membership across all the sectors. And as Dr. Nyalita has mentioned, that we have quite a number of philanthropists represented at the private sector. And what gap we have is probably them being able to know what the need is and where the need is most, so that they can be able to partner. So what needs to happen is probably repackaging this information, making it palatable to the private sector captains of the industry, and showing them the business case in that, showing the need, and also showing what is that where the private sector, like when you talk about productivity, what does this, the prevention and elimination of these diseases, how can they really impact in terms of improving productivity of the workers. So for us, we have quite a number of champions that can join this journey, only that they are not aware that there is a need, and being given the proper guidelines on how they can support these interventions. Thank you.
Thank you. I believe I see Daniela is looking at me, which means my time is almost over. But to summarize, I'll start with KEPSA's submission. Ourselves at the End Fund and our partner AMREF, in collaboration with the Ministry of Health, Dr. Sultani's office, and also Wycliffe's office, we are available at any time, and we'll be reaching out to you shortly to see how we can work together in terms of packaging that information. So we see that from what I'm gathering today, we have the basics, which is the knowledge, and making sure that we are presenting this information in a way that is palatable to the more bigger policy issues. How do we make giving, especially for philanthropists, better attractive, and looking at tax incentives? And I think KHF, I see that as a big part of what we can do together on the other extreme in really seeing how we begin to influence policy so that giving is a lot easier for Kenyan philanthropists and for others in the private sector who wish to give but get taxed twice or 3 times through that giving. So thank you from the End Fund and our partners. I want to appreciate our First Ladies for coming. I believe our session as the End Fund is now coming to an end. So thank you very much, KHF, for hosting and for leading this process. We very much appreciate. This is the beginning of our partnership. If you want to get in touch with us, please reach out to KHF, or you can also reach out to us. You can look at our website, theendfund.org, and we will be very happy to respond to you at any one point. I am based here in Nairobi, Kenya. So are my colleagues Irene and Duncan, also based here in Nairobi, Kenya. So we are very happy to respond and come to your office, especially KEPSA. If you need us, we are happy to come and pitch for neglected tropical diseases. Thank you very much.
Thank you. Thank you very much, End Fund. That was a very engaging session. Together we can end our to take us through the member session. Asante sana.
I thought I was done for the day. Good afternoon once again. Where I come from, you take the microphone and you promise to do some work, and then you hand it over to a lady to execute. So I'll shortly be handing over to Nyalita to do what needs to be done. I didn't get, as I said earlier, our guest was required somewhere else, and you all understand how the health sector is at the present time. But if I had had a chance, what I would have said is that in this room is what we need to solve our country's healthcare problems. Because we have the two first ladies from the counties, and the counties are very important, very, very important in healthcare delivery. We had the Ministry of Health very well represented here to provide leadership for the sector. We have we from the private sector, both for profit and not for profit, who are also extremely important in delivering the healthcare agenda. What we need is better partnerships. What we need is better knowledge. I heard my brother talk about data. Data is extremely important, not just in terms of where these neglected tropical diseases are, but even in knowing where help can be found. Because today we have children with cleft lips, and we have hospitals that provide free cleft surgeries, such as the one I run, such as Gertrude's, and many others. But that knowledge may not be available to everyone across the country, so that kids are matched with institutions that can give them care. And there are many other examples of people who are in the healthcare space, whether it's the likes of Kikuyu Hospital or the likes of the Lion Hospital. There are many people who do something in healthcare. And I think one of the challenges I'm taking away from here, having met the first ladies, is the need for somebody, hopefully KHF, to provide that networking so that those who need resources also know where those resources can be found, because the worst and the most expensive commodity on earth is ignorance. We pay a huge price for not knowing where things can be found, either in terms of researching or in terms of completely missing out because you simply do not know. As a good book says, where knowledge does not exist, the people perish. Today is a special day in several respects. The first is that we are meeting one day after Mashujaa Day. And Mashujaa Day is a key reminder of our founding fathers' commitment to getting rid of disease. So I want to remind each of us that the founding pillars of this country was one, umaskini, and we've talked a lot about poverty today. Two was ujinga. I think we've done pretty reasonably well with ujinga, although at times when you hear Kenyans talk, you may be forgiven for not realizing that we've done quite a lot of work eliminating ujinga. And thirdly was disease. And disease is our job. And it's a good reminder that we have a lot of work to do. It's also special because this is the first forum I've personally attended where the counties, the non-state actors like AMREF and the End Fund, the not-for-profit and for-profit organizations are all in one room with the central government, because that's what it will take to ensure that we do something serious about disease. And it's also special because yesterday we are given more freedom. We were rewarded for having been responsible. We were rewarded for having worked hard as on an all-of-country response to reduce our COVID positivity rate below 5%. So we are freer than we were 2 days back, and it is freedom we have earned just like we earned freedom in 1963. So I want to encourage all of us to learn all the lessons we've learned from COVID, because COVID has required all of us to make a response and to participate and to give some effort to remember all those lessons so that going forward, we do not go back to working in silos. There are many areas we could have worked better, but we've definitely worked quite well together under the leadership of MOH, and I think Kenya has fared significantly better than much more endowed and richer countries as far as COVID is concerned. So let's commit and go forward, and whenever somebody says that is not for the private sector, we remind them when COVID came, we were doing testing, we were doing isolation, we were doing everything. We were manufacturing drugs, we even made masks when they couldn't be imported. We responded and responded extremely quickly. And I dare say that one of the reasons we made progress is that the private sector could respond because the decision chains are shorter. We responded in some ways faster than the government could do. So if you look at the pre-COVID number of isolation beds, private sector and government, ventilators, private sector and government, you will see that the biggest growth has been in the private sector because we could mobilize resources quicker. We don't have annual budgeting cycles as tough as the ones that the counties have to deal with. And as I said, the decision chains are much shorter. So let's continue to work together to serve our people much, much better. So without further ado, Nyalita, I would want you to take over and take us through the remaining 50 minutes so that we can all go and do the other important things that we all have to do. For the new members, karibuni sana. We hope to serve you and serve you effectively. You're vaccinated like me.
Thank you, Chair. Quickly, I will just take on what we would have loved you to do it, but I know I didn't give you a proper brief, but it's fine. So next, we'll look at the new members. In terms of new members, since January, we've had very many members join us. So this is September to October. We have Crown Healthcare, Wheels for Life, Africa Biosystems. They joined us on Friday. Please welcome all of them together. Premier Hospital, Technology Associates, karibuni sana. We appreciate you for that. Next slide. Yeah, so between March, April, and May, we had Emergency Medical Services, Evercare, Elephant, Bio-on-8, Site Savers, and Sai Pharmaceuticals. Next slide. And January and February, we had ARC, Stanbic, Thinkwell, Harry, Ponea Health, Zawadi, ZBS, Pract Health, Convenient Medical Services, and Helium Health. So please help us to welcome our new members on board, and please, we are looking forward to having many more in the new year. So karibuni sana. Next. In terms of advocacy, we've been very active over the last, since the last meeting. We've had, most recently, we had a breakfast meeting with the Acting Director of Medical Services for Promotion and Preventive Care. And also, it was a privilege also because in the same meeting, we had a similar forum with the End Fund. Next. Then we had, I'm sure you've received this, and by the way, we are also communicating these updates in our newsletter that comes out once every 2 months. So KEPSA-led private sector vaccination program, I think you are all aware, where the private sector has put in money to buy vaccines for their members, for their employees, dependents and also the community that they live in. Led by KHF is supporting the pairing of these institutions with the KHF members who are accredited. So in Nairobi, we had 7 organizations that were, 7 healthcare service providers who are doing that. Metropolitan, there was Avenue, there was Gertrude, there was, I think, MPSHA. I cannot remember the others, but they were all 7, again, communicated in writing. Now they are out into the counties, and in the county level, mainly the institutions that are accredited in private sector are not many, but the ones that have been paired up with are mainly RUFA facilities who are members of, and RUFA is a member of KHF. So I'd like to say thank you to Sitonic. It's not been an easy job, really supporting KEPSA in ensuring that they get the support in terms of vaccine administration. Next. Then, of course, we had our chair and the board members meet with the ambassador of Kenya to Iran. It's not a Kenyan embassy in Iran. I keep on telling Edwin, where are you? And Leah. The embassy is in Iran, so they met with the ambassador in Nairobi. But nevertheless, we've continued to scale up our partnerships and our engagements just to make sure that, our first ladies didn't know we exist, and yet, we are core in their objectives of their, what they're delivering to their people. So that's an opportunity area that we're going to scale up as time comes by. Fund is going to be a very important partner because those are the kind of initiatives that we're looking to, work hand in hand to support them. Next. Okay, I think my phone is slow, yeah. So we also, you remember this dialogue about vaccination and private sector, where our chair participated alongside other key stakeholders and the Ministry of Health. Next. Under the Nation Leadership Forum. So what we have done also is, you will realize, with the bills and that are coming up, NHIF, there was a breast milk substitute, etc. What we did was to start having what we call town halls, to deliberate as sector players and come up with a common, thematic areas or common position which we now send to the Senate. Now, very important, that is outstanding and urgently needs to be done, and we have a deadline of 27th of this month, is the NHIF bill is in front of Senate. So our plea is to the NHIF Healthcare Financing Committee to really take up and schedule a town hall by mid next week so that we can be able to submit our memorandum in time to Senate. So we must not miss that opportunity. But along the line, we've, as much as possible, tried to ensure that we are ahead of the game. We are providing our feedback as much as possible. Next. And one of the things also the board and management are doing is also to reach out to the different leaders, government leaders, just to make sure that we sensitize them on thematic or upcoming issues in advance, so that we are not always, firefighting, but we are informing policy, we are sharing, but also the good stuff that we're doing, that they're always aware. Otherwise, we avoid coming across as always, the ones who are complaining after the fact. So that's something we want also to change. In terms of so there will be a strategic plan, 2022-2025 process coming up. Thanks to KEPSA, they will be funding it. So please, as soon as it's up and running, the process kicks off, we'll let you know, and we urge you to support us. And also just for you to know that we will be having some advocacy and board governance training for the committee leaderships and also governance for the board coming in, courtesy of KEPSA sponsored, first week of November. So just some updates on that. Now, committee updates. I want to call upon those committee chairs and vice who are here to just come forward so that you can take as the team a quick update on what you've been doing in the last couple of months, and what is your aspiration for next few months before the end of the year? And then when we're doing the strategic plan, of course, the vision for the following year will come up. So under committees, which one comes first? PPP. So the PPP, John, then followed by, those who are here, please just. So John is the vice chair of the Public-Private Partnerships Committee. Where is the guy of sanitizing? Okay. And then Oduor Otieno, if you can get, oh, it's joining online. Okay, fine.
Thank you. One of the areas we've been looking at as a PPP committee is the private sector involvement in development of health products and technology document, supply chain strategy 2020 to 2025. The proposed intervention is private sector plug-in through technology and data quality. The expected impact is to have our say, or to have the private sector say where the document is being developed to avoid objection and reaction to a finalized document. The other area is COVID-19 vaccine deployment, and the proposed intervention is to assist MOH, is to support MOH in terms of communication and distribution strategy, a diverse system that can be used to aggregate data, recruitment, and enlisting of more private sector and community health workers. The expected impact is to minimize vaccine apathy, management of data during rollout process, and vaccine distribution. The other area we've been looking at is KHF representation in MOH technical working group, meeting with relevant persons to align and ensure private sector representation in all technical working groups. The expected impact is private sector inclusivity and participation in various policy formulations, meeting. There's no objection and reaction to finalized document. The fourth one is Wheels for Life project, endorse and implement the project at the NHIF framework and mobilize strategic partners of funding. The expected impact for the same is reduced maternal mortality, quality, accessible and affordable maternal care, and the last one we're looking at is having a town hall with all KHF professional association, and the expected impact is to discuss value proposition of KHF to professional associations. So thank you very much. I stood on behalf of our chair, Dr. Ann. Thank you.
Thank you, thank you, thank you. Next is healthcare financing, and healthcare financing, I've been asked to take this one, I think. Yes. So basically, a lot of the stuff around healthcare financing has been, health facilities reclassification, and Dr. Walter Obita, who is a KHF director and also the sponsor or the support for healthcare financing committee, will be attending an MOH or KHPA organized workshop to give us an update, to discuss this further. I'm sure it was highly flagged by RUFA, came as a surprise to everybody, and the ministry agreed to have a stakeholders meeting. So that KHF is represented in the discussions that will be held. Then we have the NHIF amendment bill. It's now at Senate. We have 27th of this month to submit our memoranda. That one we cannot afford to miss. Let's push it. The healthcare financing team, secretariat, let's make sure that next week, latest Tuesday, we have a town hall, and then Wednesday we have a final document that can be submitted. Of course, there are other NHIF issues about reforms, about pending bills, COVID medical, whatever, cover and accreditation. We have reached out to the NHIF CEO to have a session with us on this. It's not, we've not managed to secure an appointment yet, and we continue pushing. We have also escalated it through KEPSA, so we are trying all means and ways to make sure that we have that dialogue around this. What we know arising from last week's session that we have, a consensus building, payer provider engagement, phase 2, validation workshop and consensus building, basically talking about what are the issues that are ailing the industry. And in this case, we had a forum for all the players, public, private, and also development partners, which was very informative. And a lot of insights were shared. As soon as the issue paper is out, we will be able to share with you, with everyone, in not only our members, but also all the stakeholders. The idea is to take the joint action items to the next phase of implementation. And the things that came out from there were basically tactical strategy, but more important policy proposals that again, and that will be also forwarded to the ministry to see how that can be incorporated. Essentially, at the end of the day, we are looking at universal health coverage. And then the UHC enrollment, we were given an update during that session, and also in other forums that these have been identified. About, I think, 6 million. Initially, the cover will be for 1 million of them. At 6,000 each, that's 6 billion, and so on and so forth. So, starting to kick off, and we continue to get updates as it goes on. Benefits package, I don't know how many are familiar with that. I know during when we were having the session in Naivasha last week, NHIF was also sensitizing the providers on the new scheme, on the UHC scheme. So once again we have the formal details about that, we will be able to share with you just for your information and update. Payer provider initiative, this is what I've just spoken about, very good initiative, and we are moving to the third phase, which is basically the implementation phase. But the issue paper is what is important that we share with you as soon as the information is, the paper is finalized by the consultant. So that's it on healthcare financing. Next one is human resources for health. Eunice Wanjiku.
Good afternoon, everybody. I'm presenting on behalf of our chair, who is not able to be with us. There are a lot of areas that needed the attention of the HRH committee. However, the committee zeroed down on 3 specific ones. And the first one is the issue of the unregulated healthcare providers. That's the community health workers, the emergency medical technicians, and health records and information officers. The proposed intervention was the engagement of all relevant stakeholders in the health ecosystem towards having a regulatory framework for the unregulated cadres. And from this, I'm happy that MSP was able to present today because they have been a very good support in the area of advocacy in the counties and also with the government. And they are also guiding that process, and also in the development of a curriculum for all the cadres, and they are all in different stages of development and almost being completed. The impact will be Regulation will ensure mandatory training and practice standards, and this will ensure progressive attainment of the highest standards of quality in provision of health services, and especially for these ones in the pre-hospital care or in the pre-hospital setup. The second one is health labor export initiatives and opportunities and threats for private sector. And the proposed intervention is the private sector input in the health market labor analysis to inform sustainable health workforce policies and strategies in Kenya. The impact, of course, will be evidenced by informed policies to ensure expatriation does not weaken the existing health system. The third one is the COVID-19 recovery initiatives and the vaccination rollout. And this one increases human resource for health involvement, particularly community health workforce, in community engagements to increase their vaccine uptake. And different arrangements have been done towards this, and we've seen an increase in the number of responders or health workforce that has taken the vaccine, and also maximize in public-private partnerships in Ministry of Health vaccination initiatives. And though the impact, of course, will be an increased vaccine uptake to save lives and livelihoods. Thank you very much.
Thank you, Eunice. So next we have health regulations, quality and standards. We have Odor Otieno online. Odor, please go ahead.
Thank you, Daktari. Good afternoon. Leah, kindly flip the screen.
Odor, you're on mute.
Thank you, good. At the committee level, during the quarter, we had 3 issues that we handled. One was around the vaccine hesitancy. And as a committee, our key proposals was to look into ways of engaging in advocacy in terms of communication. And
Odor, we can't hear you. We are trying to fix the...
to ensure that we have a wider reach of care access sites for the vaccination, for COVID vaccination activities. This basically we looked at increasing access and also reducing the hesitancy that the public might have encountered. The second issue that we had was around having a framework of private and public sector engagement in relation to quality improvement and collaboratives. And with this, the committee is looking at having a way in the long term of reducing the care gaps that may exist across various healthcare facilities within the private sector and also the public sector. The third issue that the committee also had a look into was the breast milk subsidies bill. And as a committee, we were able to have a town hall meeting and put up a private sector position paper on this. And we did present this to the parliament. And this, as a committee, we are looking at this private sector arm in terms of looking at increasing access to the subsidies or the care services that babies may need and want in the market. And also the other impact here is basically looking at making the ease of doing business for the industry players that are within the private sector, so that as a country or as a private sector, we enable within the country. So we only had 3 issues, and that was just brief as that. Thank you all. I was standing in for the chair of the committee. Over to you, Anastasia.
used for finishing, for manufacturing of finished formulation is where the HS code will now have a sub-HS code under it, a sub-code under it, so that the products come in duty-free. Remember, all this cost is not being borne by the manufacturer. Ultimately, it's transferred to the patient. So when it's transferred to the patient, the basic, one of the big four agendas you had see is also at stake. Affordability is at stake. Access in terms of having a good quality product at an affordable price is also at stake. So this is what we're trying to wipe away, but through the normal channels, so that once and for all, everything is sorted, and going forward probably in the year 2022 and going forward, we will not have these kind of issues. Yes, there's also an issue of zero rating. Now, for those who understand the mathematics or those who understand the financial terms, there's zero rating and there's exempt. When the products are zero rated, you can't claim, when the products are exempt, you can't claim the input VAT. That means it's a cost of doing business which is added to the cost of the product, and hence making the product more expensive. So what we have pitched for is zero rating on these products. That means the input VAT can be claimed back. When I mean input VAT for the layman, it means, for example, if you're running a pharmaceutical distribution company, you have services that are rendered by cleaners in the office. You have files, office stationery, computers that are bought which have VAT on it. So your input, that is your input VAT. So when you give out the products which are VATable into the market, you can offset it against the input VAT and hence save on cost. So you're not transferring the cost of the VAT, which is 16% to the patient, but you're offsetting it against the input VAT because the government has already claimed this VAT from those service providers that have provided service to you. Yes, currently we have had a very tough battle with regard to ensuring that we have enough oxygen supplies in the country. So as we speak, so far we have good capacities built up in many hospitals. We have enough oxygen concentrators that are there in the country and can take care of the patient needs for now. So as we speak currently, because of the liaisons between many multi-agencies that were into importation and distribution of the product, we have managed to curb the issue of lack of oxygen in the country. Also, there's a local manufacturer that has almost been approved, which is going to manufacture medical grade oxygen for the Kenyan public, and probably we could also look at it for the export market as well. So that will be a revenue earner for our country. I think I have captured. With regard to the taxation, we have a technical working group, which is a multi-agency technical working group that we are in formation together with the Ministry of Health and the Treasury and the KRA and Customs. So, we would look for member organizations to front people to be part of this technical working committee, so that any decisions that are taken with regard to duty or imposing taxes on the product or change of regulatory framework with regard to the product can all be first discussed as this technical working group and then arrive at a legislation so that it benefits the country. That's it from me, unless there are any questions. Thank you.
All right. Was that the last committee? Yeah. Okay, great. Okay, so there is KHF, events and activities. I believe there's a slide for it.
Yeah, sorry, I forgot to mention this one. So for the activities that are coming up, please mark your diary again for the 18th and 19th of November. We will be having our first ever annual health summit, KHF in partnership with Strathmore Business School. It will be at the Strathmore Auditorium. We are just in the final stages of confirming the agenda, so tomorrow we should be able to send out the agenda. We are calling on you, please, to sponsor, come in and sponsor. we have already shared the package. There's a new, there's something that we'll add to the sponsorship package where you'll have an opportunity also to showcase your organization, your products online on a platform for a month at a very discounted fee. So in our next issue of the sponsorship package, you will be able to get that opportunity as well. So we are looking at different, so we have headline sponsor. We are calling out for headline sponsors, and amount is 1.5 million, and the benefits are, as you can see there. In addition, you'll also have that opportunity to stay online for a month on the platform. So that's one. Next one is gold sponsor, 1 million, 20 minutes PowerPoint presentation. You also can get a slot as a panelist, and so on and so forth. Then the next one is silver sponsor, 750, 15 minutes presentation. And the presentation is basically to set the mood for the, or to set the stage for the panel discussion. So this is very critical. Next, bronze at 500,000. The information is there on what you get as a benefit. Again, we have shared this in the past. We will continue to share with you. We are requesting you to come forward and sponsor. Next. Standard sponsor, 250,000, 5 minutes PowerPoint presentation, co-branded event, etc. Again, you stay online for a month. Yeah. Once that one goes live, and you should go live by early next week. The idea is also to ensure that you go live before the event and you stay online for at least a month. That's a new innovation we were just shared with today morning. Next. Again, an opportunity for each one of us organizations also to showcase in a physical booth at the Strathmore at a cost of 50,000. Again, we'll also add in there that you also stay online for a month. That's the idea. But there will be those SMEs or small organizations, it doesn't matter the size, who just want to showcase their stuff online. You can upload your videos, etc. We will show you how it works. That we will formulate and confirm how much that's going to be. But I thought it's quite an innovative idea if you really want to connect businesses together. Next. Okay. Sponsorship pledge forms are available with the Secretariat, so please make sure your organization picks one or write to us. We will be able to give you the sponsorship form. We'll also send it out to our members and other partners so that they can also pledge. So please, we count on you to support us. So the annual health symposium is going to be held every year starting this year in partnership with the two other organizations, the Strathmore Business School, and there's another organization called Open Fences. Open Fences will tell us who they are once the opportunity comes up. We know Strathmore is also a member of Kenya Healthcare Federation, and we are asking you guys to come on board and partner with us. So please pick up pledge form, fill it, or alternatively also write to us to confirm your sponsorship package. Next. Oh yeah, sorry, projects. Let's go. Projects, MSP, you've seen the presentation, you've gotten an update. Thanks to David Owino for doing that. We've been on this journey since 2017, and I think it's bearing very good fruit. We hope next year will be another phase. Next. Wheels for Life continues to operate at a very low, wherever at the moment, but we're still, triaging mothers and providing transport. We're also looking for funding for this as well. Go on. This is a project, regional project, which KHF is a key coordinator. I'm sure you remember we called on you, there's a time we trained the health workers on infection prevention and control. Yeah. So this is what, and then the next time we did antigen testing training for lab technicians. We are expecting to get another tranche of funds before the end of the year to do a final training of trainers, and this time it will be held in Mombasa for both IPC and also for antigen testing. So just capacity building. Next. So OLEM, partners since last year, November. That's going very well. We're in discussion for another phase. We have an MOU existing for the 2 to 3 years to going forward. So this is another opportunity area for KHF, and you can see that whether you're a member or not a member of KHF, we have very good opportunities for you to partner with KHF so that you can leverage our networks, our convening power, among other things, to advance the agenda of access to healthcare for all, and also capacity building, including capacity building for healthcare workers. Next. Yes. So let me just do the, okay. Where is the sanitizer guy?
Thank you very much. I think we are here at the end. Thank you for being patient, and those who are still online, asanteni sana. On behalf of the Kenya Healthcare Federation, my name is Dr. Wala Elizabeth. I'm the Vice Chair. And I'd like to give a vote of thanks to our main sponsor, and that's the End Fund. So they have supported this meeting. They've enabled us to gather here together. I want to also thank our co-sponsors, MSP, who have worked with us the journey for a long time, and Hydraulic. Asanteni sana. I also want to say on behalf of the association, the Ministry of Health that was here, the county governments that were represented by their first ladies, and anyone else who's a dignitary, thank you so much for availing yourself. So we want to end here. As members, please plug into the committees you've had. There are 6 of them. So it's not restricted to anyone. As long as you have an interest in that committee, feel free to reach out to the admin team. Thank you so much to the admin team behind the scenes, Leah and your team. I think the digital team has done very well, and this is the way to go. Anastasia, asante sana. So without further ado, I wish to bring the meeting to a close until next time. Asante. Hello, sorry. You may serve tea, and feel free to leave at your own pleasure. Thank you.
Tell them, remember, there's no curfew.
But this bus, what's the story of the bus? They're still closed at 11.
It's open.
No, I hear the time.
There's a clarification of
Yeah.
But even before, most of them didn't stay the whole night.
Oh, you're saying for regular business before COVID?
Even regular.
Ah.
So I'm not staying. Clubs are allowed to go out morning. But by kawaida.
But most people became clubs, eh?
Yesterday, because of the market. 2:45 is when we close. I want this next.
Clubs are, I think, allowed the 24 hours. Yeah? That's why they are called night clubs. Because they are allowed to stay the whole night.
And then they close in the morning when we are now woken up.
And the rest of us are waking up. Guys are living.
I have a call with Mario.
Where you are calling? How is the drug world? Except ones from Wala's place.
And her place. She owned her.
We have a policy position for SPSK.
Nasemaje?
That we should allow medicinal.
Nakubali hata mimi. Yes.
See, hata nani, the left can empty your
to me, even prostitution is illegal.
Yeah, anything.
Yeah, because it happens anyway. So you might as well bring it out of the cracks and the darkness.
It's a